I'm Richard Martin, and I'm a family doc in Grand Prairie. As a non-Indigenous settler, I want to acknowledge the fact that I live and work on lands of Treaty 8, along with Treaties 6 and 7. These lands are the ancestral lands of many Cree and Dene First Nations, Métis settlements, the Métis Nation of Alberta, and many Inuit peoples whose knowledge, guidance, and wisdom has watched over these lands for countless generations.
Je reconnais respectueusement que je suis située sur la terre du Traité 6, territoire traditionnel des Premières Nations et du peuple Métis.
I wish to thank and acknowledge all of those people whose wisdom stewarded these lands for millennia in the past, and hopefully we continue to share and learn for the millennia in the future.
I'm Dr. Janine Karpakis, a family physician here in Lethbridge, which is Treaty 7 country. I am an international medical graduate from South Africa. There are significant deep-rooted stereotyping of Indigenous people when it comes to substance use disorder medicine and other psychosocial issues. And it's interesting to note the similarities between my childhood exposure of racism in South Africa and the impact that colonialism has had here in Canada. It is my opinion that we as a medical society need to acknowledge the presence of systemic racism to start conversation towards bridging the divide in order to allow for healing.
My name is Dr. John O'Connor. I'm a family physician and hospitalist here in Fort McMurray. Myself and my wife have been honoured, humbled and privileged to provide primary care services to 3 of the Indigenous communities outlying Fort McMurray, specifically Janvier, Fort Mackay and Fort Chip. Fort Mackay and Fort Chip are on the Athabasca River and they're both downstream of the tar sands. We have been documenting, managing and treating the health implications from living in such proximity for many years, although promised health studies for years have never had one iota of effort to start such a study. It is of vital importance that everyone realize that the land being exploited is actually land that was granted officially to Indigenous communities back in 1899. That's the land of Treaty 8. This land is being destroyed, and along with it, the culture of the people that have been living on this land.
Welcome, everyone. And I'm just going to give a few minutes while the waiting room is opening. I'm Kathy Scrimshaw, and we'll be starting shortly. So it is 7 o'clock, right on the nose. And I would like to start with a land acknowledgement. I'm Kathy Scrimshaw. I'm a family doctor, and my internet's a bit unstable. I'm going to try my video on. I want to acknowledge that I'm a settler physician, and I work on the traditional and the present day territory of the Blackfoot Confederacy down in southern Alberta. And they are members of Treaty 7. We would like to recognize that we are webcasting to and from many different parts of Alberta, and actually from across Canada today. The province of Alberta is located on Treaty 6, 7, and 8 territory, and is a traditional meeting ground and home for many Indigenous peoples. I would like everyone to take a moment to reflect on what truth and reconciliation means to you and consider some of the calls to action from the Truth and Reconciliation Commission of Canada, particularly as they relate to health. Thank you. And so, as I said, I'm very pleased to have everyone here tonight to join a virtual collaboration forum sponsored by the CMN, or the Collaborative Mentorship Network for Chronic Pain and Addiction. I'm Kathy Scrimshaw, and I need to disclose that I am a part-time paid employee of the Alberta College of Family Physicians and a paid part-time employee of Alberta Health Services in the Indigenous Wellness Corps. I also want to mention the Collaborative Mentorship Network's virtual collaboration forum receives financial support through the Alberta College of Family Physicians, who receive that from a Health Canada Substance Use and Addictions Program contribution. The event does not receive in-kind support, and it's presented by the Alberta College of Family Physicians. And just the usual housekeeping, the webinar is being recorded, and by participating, you understand and consent to the session being made available for all ACFP webinar registrants. Recordings may also be used in future promotional videos and content libraries, CPD. Some people use it for teaching. So by participating in the chat and on the live Q&A, your name will appear on the Zoom account. So we just want to make sure that you know those things. And it is in Zoom meeting. And so we do have the chat ready for you to enter your questions as they come up tonight. And our speakers tonight will have plenty of time to have some interaction and hopefully some discussion that is valuable for everyone. And with no further delay, I'd like to introduce our two speakers. Our first speaker tonight will be Dr. Monty Gosh, who's probably not a stranger to anyone that's on the webinar tonight. He's an internist and an addiction specialist, and he works in Edmonton. He works in Calgary. In Edmonton, he's working in the University of Alberta Hospital. In Calgary, he's at the Sheldon Schumer. I believe he's at the Alex, sometimes does clinics at the Drop-In Center and works at the Rocky View Hospital as well, doing addiction medicine. He's an innovator and a teacher, and he's often that friendly voice on the opioid line on Rapid for us rural and remote docs. So we're really pleased to have him coming to talk about some of the innovations that are occurring in Alberta. And I'm really pleased to introduce Dr. Alexander Cottarella. He is a bilingual family physician who's got enhanced and specialty training in substance use health issues. He's the new CEO, I think 3 months, the Canadian Centre for Substance Use and Addiction. He's known for his development of innovative clinical programs. He decreases barriers to care and improve access to better standard of care in primary care. He's a family physician, and so we're really pleased to have him talking to us about Canada's new guidance on alcohol and health. And it's quite a different approach to guidelines. So we're really hopeful that the family physicians and other practitioners on the call tonight will help give their opinions on that new guidelines. So with no further ado, Monty, I think you can steal the share and start your presentation. Thank you.
Thanks so much, Kathy. And hey, everyone. I'm like super grateful to be here again and glad to see so many familiar faces in the participant room. Yeah, again, glad to be here and talk about some innovations that are going on in Alberta. You'll catch a common theme here. A lot of these innovations are around the COVID pandemic. But first and foremost, of course, I want to acknowledge the fact that I'm working on Treaty 7 territory in Southern Alberta, but I also work in Treaty 6 and Treaty 8 territory as well. Again, I want to acknowledge also the fact that these are unceded territories overall and continue to be. This is my disclosure slide, and nothing really major to disclose here. I do work for Alberta Health Services in the Alex and the Calgary Drop-In Center, and a lot of these projects are funded from Health Canada, SUAP, Alberta Innovates, and Healthcare Excellence Canada, and CIHR. So first and foremost, I want to go over some basic stuff. You guys probably already know this, but the drug poisoning crisis really hasn't let down. While things have improved slightly since things have opened up with the pandemic, they're still not the best. So at the peak in Alberta, we're reaching about 6 overdoses a day. We're right now around to about 3, not really quite at the pre-pandemic levels of 2 overdoses a day. And even 2 overdoses a day is too much. We really need to reduce this much more. As you can see from this figure right here, Alberta does see a fair chunk of overdoses. We're right behind BC, but third in the country overall. Here you can see what the pandemic has really done to us. These are old numbers, of course, from the Alberta Surveillance Data website. But our numbers during the pandemic were quite a bit higher than where they were before pre-pandemic. So we're reaching about at the most 6 overdoses a day throughout the province. And again, this is not quite the most updated slide right here, but things have improved as of late. We believe, especially because the toxicity levels of the drugs have probably decreased to a certain extent because the things have opened up. They're not as concentrated, but we still haven't reached the pre-pandemic levels that we're hoping to reach. So key reasons that the opioid crisis and the drug poisoning crisis did worsen during the pandemic was that those who were living with poverty, experiencing homelessness, were having more potent concentrated versions of opioids. There was lots more benzos that were coming into the market as well. There was conversations that were broadly focused around addressing barriers to service and treatment access. So a lot of these individuals were not able to access supervised consumption sets that were reduced capacity. They were also not able to access treatment beds and detox beds as needed as well. So innovation was needed to improve access to care and supports, and key areas that were focused on in terms of change included changes to frequency of in-person appointments and urine drug screens, changes to carries and carry protocols, and then also changes to how services are typically delivered within our province. So a bit of background, as I spoke about before, most of the trade routes and most of our fentanyl that's coming into our province, from what I understand, from what I hear from our provincial government, comes from China mostly. They come in small vials, they get shipped overseas, get packaged in small little boxes, and they're really, really tiny, hard to capture through normal screening routes. What happened with the pandemic was that because there was less of this coming, there was more potent versions of opioids that were coming into the local market. We also saw some increase in local production, especially with methamphetamines. There was decreased drug tracking capacity overall because of the pandemic. And there's also, of course, newer and more potent opioid analogs and also increased benzodiazepine use. One thing that we've noticed, at least in Alberta, which I think is interesting for you guys to know as well, is that we're starting to notice that people are overdosing more later in the day. This is very anecdotal, of course, but what we're thinking is happening, for example, is that benzos are being compounded. Benzos have, especially alprazolam has a long half-life, for example, or tizolam, I should say, also has a long half-life. And what we're seeing is that you take your first dose in the morning of your opioid with a mix of benzo, then you take another dose in the afternoon, another dose in the evening, but those benzos are still around for almost 12 to 17 hours, and they compound each other, and we're seeing that people are typically overdosing more so in the evenings. We look at some data from, say, the drop-in center, for example, or Alpha House. So things to be aware of. There's also the situation where we have people who are using alone and because of self-isolation. Talking about benzos again, we can see here that especially with tizolam, there's been a lot more that we're seeing in our opioid compounds. And this is just, again, to sort of add to the concerns that there's not enough fentanyl coming in, people looking for higher highs. And in June, we were seeing 18% of expected opioid samples testing positive for benzos. And this is from the BCCSU, by the way. So in terms of our approach to addiction, we've got the sort of 4 pillars that Health Canada has identified as being our public health approach. And that includes enforcement regulation, prevention, harm reduction, and treatment. One thing that I like, so just kind of moving towards the treatment side of things, one thing that we've seen a lot of and that has sort of changed our practice during the pandemic has been changes to specific aspects of our services. And this includes changes to our carries, or changes to carries, decreased access to consumption services, and then also decreased access to treatment facilities, which caused a lot of us to pivot in terms of how we approach our the population. So in regards to carries specifically, one of the more traditional strategies that we've had to reduce risk of diversion has been to provide daily witness carries at pharmacies or in clinics. The downside of this, of course, is that it's often done without the lens of being patient-centric, but rather focusing on reducing diversion, but also focusing on profits. We see a lot of people providing providing daily dosing of Suboxone in many of these clinics, which doesn't make any sense because Suboxone, buprenorphine should be carries right off the bat. That's what they're meant to be, right? That's why the drug was sort of manufactured in the first place and tested in the first place. And we also have multiple patients who do request take-home carries on a regular basis because there's barriers for them to going to these pharmacies on a daily basis, whether that's geographic barriers, whether it's lack of transportation, whether that's life in general, like them having to go to work, spending time with their families. We know that carries can be a barrier for a population. And this was a particular study that was done in Ontario, which was a sort of large database study that was looking at what was happening during the pandemic with carries in comparison to people who were not receiving carries. And what they found, as you can see here, was that there was a reduction overall, or there was an improvement, I should say, in regards to potential opioid overdose, discontinuation of therapy, interruption of therapy, all-cause mortality, especially with methadone in regards to providing carries. And same thing we see here with buprenorphine as well. The results from the Optima trial haven't come out as of yet, but it more or less provides the same sort of picture that carries are beneficial to clients. Carries can be obstructive to clients maintaining therapy. And that we need to be a bit more liberal with our prescribing in terms of providing carries. And this has definitely changed my practice. I was very much a stickler for methadone being daily witness dosing, but especially with my clients who are reasonably stable, instead of having a strict protocol of having 3 urine drug screens that are negative first, and then providing only 1 day of carries until each urine drug screen comes back, adding another day. If they're doing well, I provide them with 3 to 4 days of carries and see how it goes. If that's going well, provide them with a full week or 2 weeks even. Again, it all depends on the client. We want to make sure, of course, that they're doing well, that it's not being diverted, that there's no risk of someone else getting their hands on it. But again, you got to weigh that with the risk of them destabilizing and the risk of them going back to street opioids. So this is an opportunity to not be as strict and be more patient-centric. One of the things we've also seen is that there's been a huge expansion of virtual care. In Alberta, we've been really lucky. We've had the VODP for a while, but the VODP, which is Nathaniel Day's program, has really exploded during the pandemic. I think they were really mostly operating out of central Alberta prior to the pandemic. And then as soon as the pandemic hit, they were basically touching every part of the province. So for those of you who don't know, the VODP is a program in which a client can access almost within the next business day any OAT, whether that's slow release or morphine, buprenorphine or methadone, and sometimes immediate access as well. Which is great because we know a lot of other provinces out there don't actually have that capacity. We know that I hear about clients in Eastern Canada who have to wait 3 months to get access to OAT. So the fact that you can access OAT the very next day is a huge thing for our province. The one thing to note is that CRISM has created some new guidelines around this as well, which is amazing. If you ever want to know how to sort of maintain your practice, how to organize your practice around telemedicine supports. Another thing that sort of happened with the pandemic was a home detox. So one of the things that we started at a RAM clinic in Calgary was home detox management. And this takes a variety of forms, but basically we either do ambulatory care in which clients come to our clinic every day to get seen, or we provide them with medications to stay at home, provide there's a loved one. They have a strict inclusion-exclusion criteria, of course, in which they can do their own detox at home from alcohol, meth, opioids. We actually get them onto a home protocol, induction protocol for buprenorphine or other substances of misuse. We also have a program that's partnered with the virtual hospital as well as with community paramedics in terms of providing additional supports for clients who are withdrawing. This is coming in the horizon. There's a new ambulatory alcohol and substance withdrawal management protocol that Alberta Health Services is finalizing at this time. So this should be out pretty soon. So if you guys are interested, feel free to look into this. In terms of other programs, we've got online treatment programs here, like 12-step treatment programs for your clients who want to access these resources. These are especially important, I would say, in rural communities where they don't necessarily have access to these resources right now. There's Smart Recovery Online, AA Sober Living Online. I will be sharing the slide deck later on, so you guys can feel free to grab these resources for your patients, especially in rural communities. The last little thing I want to talk about in terms of virtual care is virtual harm reduction. Harm reduction, as you know, is one of our pillars for healthcare, and I want to specifically talk about the National Overdose Response Service. Many of you know that in Alberta, we've been trying to get this off the ground for 3 years. We were unsuccessful, but during the pandemic, we were able to partner with a few agencies across Canada to help get this off the ground, especially Grenfell Ministries in Hamilton, Ontario. Some background here, 60% of overdoses occur in someone's home. This number varies from jurisdiction to jurisdiction. It was as high as 70% in Edmonton, as low as 50% in Calgary. But regardless, the vast majority of individuals who are overdosing are overdosing by themselves in their own private residences. One of the things we've seen is that, especially from the literature, is that supervised consumption sites are the gold standard. There's been 0 deaths and 0 mortality inside these facilities. But when you look at the data, they're only effective to reducing mortality rates within a 500 meter radius around them. We know from other studies that clients are not willing to walk more than 1 kilometer to reach these sites. So it's a very much a barrier for them. And we need to have more and more of these sites, but there's other barriers that prevent these sites from popping up, whether that's political opposition, whether that's cost, whether it's staff hirings, et cetera. It's very hard to scale these up. We also know that the majority of overdoses that occur, especially in Alberta, occur outside of these red regions where you see the concentration of overdoses, usually the downtown core. And so 80 to 90% of our overdoses are actually occurring in suburban rural communities. So the good news is that overdoses can be reversed using naloxone, and that supervised consumption sites do reduce mortality, but they do have geographic limitations. And so one of our solutions is the National Overdose Response Service. So it's a phone number you can call. It's provided to individuals, much like the way you would provide a naloxone kit, and you tell them to call them if you're going to use alone. Ideally, they would first and foremost use a physical supervised consumption site. So that's what you would tell them to do. If not, you would tell them to use in a group if they can. And if that's not possible, or actually either or a group or supervised consumption site, that could be almost equivalent. But if those are not available, then you should try to use a line or spot someone that you trust. So the line works by this 188 number. They're connected to actually a paid supervised consumption supervisor now, who will stay on the line with them for about 15 to 30 minutes as they use their substance. And if the caller requires additional support, they could be provided with that. And if they're unresponsive, we usually enact either A, safety plan, or B, 911 dispatch services. Things we tell the client when they use the line is that they have to keep their porch light on, keep their pets away, keep their front door unlocked, and hide the paraphernalia. One thing we also are telling them to do now is to have a take-home bag with them, or a hospital bag with them. So basically, we've had situations now where clients will be whisked away by ambulance to the hospital, and they'll have no clothes, no toiletries, no cell phone charger. And so we're actually telling them to have a bag packed and ready to go should they overdose. The barriers that this removes is the geographic distance barriers for our clients, stigma and fear of being seen at physical supervised consumption sites that we've heard of, and also especially with what we're noticing is that the vast majority of our users are women and professionals to a certain extent, which is really interesting. And then time barriers to the service. So, for example, a lot of supervised consumption sites are only open 12 hours a day. Or just in evenings and not necessarily the weekends. And so this removes that barrier as well. And last but not least, we notice a large chunk of our population who's using the line are using inhalational routes of substance use. And we know that only 2 physical supervised consumption sites provide that facility in our country. And so this is sort of an alternative option for those individuals. Our target populations are those who use substances alone. In French-speaking populations, we have the line in both languages. And we're really gearing it towards urban, suburban, rural communities. The line, at least in Alberta, was conceived by a blue-collar worker who was working on the oil rigs. So that's another big demographic that we're targeting, especially with a large proportion of individuals who are overdosing being construction workers and blue-collar workers. And then the others who might indirectly benefit from this, of course, are frontline service providers. People like myself often would just give people a naloxone kit when they would leave our clinic and say, don't try to use alone, but this is just an additional resource that you can provide them. We're also hoping to help other community-based agencies and, of course, families of individuals who use substances. We are working in all 10 provinces and 3 territories, and there are some limitations. So as individuals who may be drowsy but not overdosing may have an emergency service dispatched to them. They don't respond to prompts. There was this big fear that we would have tons of false alarms, but you'll see from the data that we actually haven't. For some jurisdictions, the country police may not come to the call-outs, and this has been a huge barrier for some of our clients. I won't talk about this today, but we have a qualitative study that's coming out that shows that this is probably one of the #1 barriers that's been identified from people with lived experience as being a reason why they're not using these services. Paraphernalia may be confiscated by police services, and also some people overdose quite quickly, and emergency services may not arrive in time, which can be a barrier. We fully expect a death to happen, but as you'll see from our data, we haven't had any yet. So in terms of our demographics, and this is about a 1.5 years worth of data, The vast majority of our callers are female, or identify as female. We've actually just recently updated this data, so this is just slightly off, but I would say, I would say almost 80% of our callers are female. A lot of them don't actually identify their gender on some of the calls, but we've sort of retroactively looked at through the data, especially with frequent callers, and it really is females as being the mass majority. The vast majority of our callers are also calling in from urban communities as opposed to rural communities. That's something we want to change in the future. We need to figure out how to target rural communities more, because really they lack that harm reduction service. And so we're hoping that we can reach them more. And then also less than 1% of our callers have identified themselves as Indigenous, unfortunately. And so that's another target population that we need to sort of reach. In terms of our service usage, we've had over 5,200 calls and about anywhere from 360 to 425 unique callers. This is being tracked using phone numbers that we have in our log kit, as well as the unique identifiers that they provide us. None of that information is kept. It's all anonymized, of course, afterwards. But we've had some reasonable success in terms of calls and also continuation of calls. What we've also seen is that a lot of our calls are not necessarily for physical supervised consumption or for supervised consumption. Basically, a lot of it's for peer support and mental health supports, and also for information around harm reduction, and in some education. So one of the things that we never expected from the line is that we're doing a lot of methamphetamine de-escalation and psychosis de-escalation. For those of you who are at CSAM, we presented on that. We did a qualitative evaluation of our operators and people lived experience and what they felt was going on with these psychosis de-escalation strategies and mental health supports. And again, that makes it about a quarter of our phone calls is related to that. Again, it's something that we did not expect with our program. In terms of days of the week, they're fairly evenly distributed. The average call is about 16 minutes. And most callers call between 6 a.m. and 6 p.m., interestingly enough. And this is our data across the country. The vast majority of our callers are calling from Ontario, followed by Quebec and Alberta. We have had zero uptake in Saskatchewan. So when we were presenting at CSAM in Saskatchewan this year, it was pretty disappointing to share this with the group there. But again, we're hoping that we'll have greater penetration throughout the province. Opioids is by far the most substance use, followed by cocaine, I should say, methamphetamines. Most individuals are injecting, followed by smoking, which again is a huge barrier for many of our population because there's just only 2 sites in Canada that provide inhalational support. And again, we provide a lot of other supports too, so mental health crises. We've had 5 other incidences, which included fires, home invasions, domestic issues that they utilized the phone line for. And then 5 cases in which they used us as a drug poisoning line or a medication poison line. So they thought we were, someone had taken too much aspirin. They called us and we had to redirect them to the poison center. So we've had a few of those calls, but for the most part, it's been substance related. So the other thing too is in terms of our rates of overdoses, we're still in the process of sort of trying to gather this data, but our rates of overdose is about 1 in 100, which is very similar to physical supervised consumption sites. We have a bunch of data that's going to be coming out fairly soon. We'll have a CMAG article that's coming out next week, but we have our qualitative stuff that will be coming up very soon, as well as some more statistical analysis of our data that we'll be sharing very soon as well over the next couple of months in terms of what we've seen with our usage. The last thing I kind of want to talk about before I hand it over to Alex here, Dr. Paladandra, is that Cardella, I don't think I'm pronouncing your name properly, Cardarella, is wastewater testing. So this is going to be starting up in Calgary, followed by Edmonton in the near future. So one of the things that we've seen is the vast majority of overdoses are actually occurring from polysubstance use. There's lots of new novel analogs of fentanyl. And we often don't know what's going on in terms of the drug supply in Canada. In terms of toxicity, 70% of opiates are thought to be fentanyl from this one study that was done, and about 88% of them actually were confirmed to be fentanyl. I think this was actually from, taking a look right here, this is Jane Buxton's study, and it was from drug seizures with the RCMP. And then the other thing that they found was that 1% of all stimulants contain fentanyl as well, which was quite scary. When you look at our overdose data, you can see that while the vast majority of overdoses are occurring because of fentanyl, there's tons of other substances that are often mixed with this. So when we, again, look at the coroner's reports, they not only have fentanyl in their system, but they've also got methamphetamines. They've sometimes got carfentanil in there too. They've got cocaine. They've got benzos. It's very much all over the place in terms of what they're using. They're using tons and tons of compounds. So what we're doing in Calgary right now is, this is in combination with StatsCan, is that we're actually trying to test our wastewater. So we're using the LCQQQ, which is a chromatography machine in which basically what we're doing is we're detecting levels of fentanyl, carfentanil, benzos in our wastewater, specific benzos. And we're looking at them on a weekly basis to see if there's different changes in terms of the prevalence of those compounds. The other really cool thing that we can do is we can actually test the overall consumption of substances for the entire population of Calgary. So we can kind of tell what people are consuming at a given time. So we can actually quantify it that way, which is really, really cool. We also have the LCQTOF machine, which actually looks for unknown substances and unknown compounds. So for example, if we're seeing a new spike in something, a new compound, we can match it with a global database and see if that matches with a new analog of fentanyl, for example, or carfentanil. But we haven't quite started testing this as of yet, but that's sort of the game plan going further down the line. I mean, I can't share as much data right now, but what we are seeing is that we're really seeing really unique peaks around certain compounds. So for example, at the Calgary Drop-In Center, we have a huge spike in fentanyl, but while it's not a solid spike, it's sort of a wave of spikes, which means that there's different analogs of fentanyl all being used at the same time at the Calgary Drop-In Center. So very unique things that we're seeing with our data. So really our goal is to determine novel contaminants in the current drug supply in order to inform healthcare professionals. The data that we can use is actually even neighborhood level data, but we're not trying to go to that extent because we're trying to be very careful again as to how we present this information. And we're working with the city to determine how best to present this information as well. The plan is to also provide this information for people who use substances through drug alerts as well. And so our first goal is to sort of standardize how we're testing the wastewater and validate our assays, which we're currently in the process of doing. But the next phase of this will be to determine, and I'll have to come back to you guys as well, in terms of how to share this data with healthcare professionals and especially people who have experience. And so that'll be sort of the second phase of our project. This is just a comparison table between conventional drug testing. So this is at the physical supervised consumption sites using either infrared or test strips. The cost is can vary from test strips compared to wastewater. It's much more cheaper with wastewater, and we can screen a large number of agents at a time, but it's not as it may not be as real time because it takes us about a week to analyze this sometimes. We try to do it in batches. In terms of the conventional format, it can sometimes be slow depending if it's going to the RCMP or not, for example, or if it's being tested on the spot. Whereas wastewater can be reasonably rapid. We can get the results right away, but again, we need to sort of test in large aliquots, so it usually takes about a week for us to sort of determine what's going on. And then, of course, you require federal exemption to test the physical samples, whereas with wastewater, you don't really have to do that. I'm starting to run out of time, so I'm going to skip over this slide, but those are some unique things that are happening in Alberta. We have a large survey that we've got going out right now across the country. We launched about 2 weeks ago around people's perceptions of the virtual overdose response services that exist. So it's not just NORS, but there's also Lifeguard in BC and Northern Ontario. There's also Brave, and there's also, of course, the DOORS program in Alberta. We would love your input on these services, and it'll help us improve this. This particular survey is funded through CHR. To better get a chance, or to better understand what people's perceptions are of these services and what are barriers and facilitators to using these. So we would very much love your input. And if you don't mind scanning the QR code, I'd be eternally grateful. And with that, I'll pass it over to Alex.
We've got a few questions for you before you disappear. Dr. Gosh. So one of the very first questions was from Kristen, and she is saying, she's saying not all the benzos show up on our urine drug screens. And so are we assuming they're in with fentanyl right now? We're assuming when someone's using down that they have benzos. Is that a safe assumption?
Not with every opioid, that's for sure. So I think like the coroner's reports, they varied from month to month, going for anywhere from like 3% to 32%. So it varies. And then in terms of our wastewater, we're specifically testing the ones like etizolam, for example. It's pretty common. And we're seeing that it also is kind of varying as well. But we've only been running the assays for the last few weeks now. But yeah, it definitely isn't in every it's not in all fentanyl samples, for example. So yeah, it's safe to say that it's not everywhere.
Okay, great. And Jasmine, I don't know if you want to unmute and ask this question. You were wondering about, I'm not sure if she's there. Anyways, there was the housing status of study participants when they did the study about carries.
I have to go back to the study. I don't think they did. I know, Jasmine, that's a really good question because that definitely impacts how we provide our carries. One thing I do for sure is with Suboxone, especially, I don't actually necessarily require them to have a house, like a proper place to live, as long as they have something to carry their buprenorphine in. But yeah, that's a really good question that I what I'll do is I'll look at the study again and maybe answer after the question answer period. But I don't think housing status was looked at.
That's okay, Monty. I can also Google the abstract too, which I should probably keep up with the reading. So thanks.
Thanks, Jasmine. And Laura.
Laura has a question. We actually were talking about this at FMF because we had the AHS home detox document and it's disappeared from the website. And so we weren't sure what was happening. So happy to hear that it's being revised, but any reason it's gone, I think is what Lara was asking.
Yeah. Okay. So yeah, no, one of the reasons why it was gone is because we got some feedback that they wanted some modifications, and we're also doing a systematic review at the same time around it. And so basically, while we're doing that, we're sort of revising the guidelines, getting more expert opinion. I think a few of you on this phone call probably saw the new version because it's been circulated for stakeholder feedback. But we're in the process of sort of synthesizing all of that right now, and there should be a new set that's coming, a new set of guidelines that's coming up probably in the next couple of months. So wanted you guys to be all alert to that, so that that when it's just to be on the so that's on your radar, so you guys can see it later on.
Great, thanks. And I think we should be able to go ahead with Dr. Cottarella.
Thanks, Monty. That was extraordinary to hear about. I mean, NORS is just such an impressive service. And then the wastewater pieces, I think, will be a really interesting part of the coming months and years of trying to understand the drug trends in the country. So that'll be something really to look forward to. Yes, bravo. I'll start sharing my screen. Going to do the steel share that I've been learning about. Kathy, did it work? Good.
Looks great.
And just before I start, I'm going to make a shameless little plug for one of the CCSA things that they do, just in the context of what Monty was talking about. So there is something called CCENDU. It's CCENDU. You can Google it with CCSA. And you can sign up for some national drug alerts too around some of the trends that are happening. Not going to be in as real time as what Monty was talking about, but we do have a chance to kind of look at multiple sites across the country and really dig into the pharmacology and kinetics of some of the things that come out. So have a look. All right, I'm Alex Cottarella. So I receive funding from the CCSA, who pays my salary now, and some from the Government of Canada. I am still an employee at Unity Health Toronto, the hospital network in Toronto. I don't have any other disclosures at this time. And other than the honorarium that was provided for this session. I don't have any conflicts of interest right now to disclose. Okay, so this is going to be a big pivot. We're going to talk actually about Canada's new guidance on alcohol and health. So we move from the world of opioids into alcohol and health. And what's really exciting and why I'm really glad to be here to talk to you about this today is that we're going to be launching this in January, on January 17th, in fact. But we're really trying to figure out the best dissemination and knowledge mobilization strategies for this at this time. So I'm really hoping that you can look at this through this lens, especially through your own practices and your kind of own experiences, and be able to help us understand how best we can reach both your patients and you and your colleagues. As the other speakers had, just going to do a quick land acknowledgement. So we respectfully acknowledge that the offices of CCSA are located on the traditional unceded territory of the Algonquin Anishinaabe people. The Anishinaabe Algonquin Nation has been present on and nurtured this land since time immemorial and was forcefully removed from it. We're humbled to have the opportunity to present in this territory. Some of you may be familiar with the Canadian Centre on Substance Use and Addictions, others may not. This is us, this is our website, this is our Twitter, and all those other things. We were founded by an Act of Parliament in 1988. We are intended as although we receive much of our funding from Health Canada and the federal government, we are a non-governmental organization that is arm's length, that is intended to provide national leadership on substance use and to advance solutions to address alcohol and other drug-related harms. We've been around for, as you can see, almost 35 years, and we're really supposed to be a nonpartisan advisor to the government on various issues. But we are independent and, as I mentioned, a not-for-profit agency. One of the things so as Kathy had mentioned, my background's as a family physician. I've been in this role for 3 months now. One of the things that I'm particularly keen on is what the CCSA can be doing to better support substance use, treatment, health in general, and an empowerment of people seeking to help people who use drugs and alcohol, particularly in and amongst my colleagues as family physicians. So at the end of this, feel free to let us know what some of the stuff we should be doing. As the new CEO, I get to kind of rethink some of what we do as the organization. So this is a great time to let me know. If you want to send me an email afterwards, that's fine as well. I can't take credit for the work that was done. The work was co-led by Catherine Paradis, a fantastic scientist who's with us at the Canadian Centre on Substance Use and Addiction, and Peter Butt, who is a family physician and scientist at the University of Saskatchewan. He and the associate dean there as well. I don't know if some of you may have seen him at CSAM, but the two are rather extraordinary people. We were very careful in how we went through this. These are the 23 experts that form the scientific committee. And we wanted to make sure that we had guidance that was free of inappropriate and problematic conflicts. So this is actually one of the first guidance documents around alcohol that was produced without direct input from the alcohol industry. And we feel that it makes it more independent and unbiased in that way. Many of you might be familiar with this. This is what it used to look like before. 2 drinks per day, 10 per week, 3 per day, and 15 per week. It was decided to redo the lowest drinking guidelines as many things had changed in that time. And I think have learned a lot about the subtlety and changes of alcohol and how it can impact the body. You're going to be getting in January 17th, for anybody who gets most of us should be, but anybody who gets the Canadian Family Physician in their mailboxes. We will be taking out a full page ad to have the new guidance in there, but I'm going to be giving you a preview today. So how did we go about doing it? And this is again where I owe all the credit to my colleagues, really more than anything, but I'm here to summarize what they've done. So they really went to ask themselves three big questions. What are the long-term risks and benefits? What are the short-term risks and benefits of alcohol? And what are the risks for women who are pregnant or breastfeeding for fetal, infant, and childhood development? There are a number of countries that have recently done reviews of their guidance. Australia did theirs, and France and the UK. What we were able to do is actually take the systematic reviews that were used in Australia and then build on them by reviewing furthermore the ones that were done since what happened in Australia. What they were looking for specifically, the team, is where causal relationships between a particular illness or disease and alcohol had been established. And then what they did is they took the most robust and recent systematic review to establish a risk function for risk of harm, depending on consumption, and then put it all together in an incredibly wonderful and complex mathematical model, which ended up looking like this. So the first question they wanted to ask themselves is, was there any kind of protective effect? Then they wanted to ask themselves, what is the risk, at what amount of drinking per day of alcohol do you have a 1 in 1,000 risk of premature death? What we mean by premature death there, as you can see on the left, is your risk of dying 17.5 years earlier than you would have otherwise. And where is the 1 in 100 cutoff? And the feeling was that for many of the behaviors we engage in by choice, we have a kind of tolerance for something between these two numbers, but 1 in 100 being really kind of on the high end of that, and 1 in 1,000 being something that leaves people with a more comfortable level of this. So the first part was the protective effect. So the protective effect was not found to be significant, but if it was probably at 1 or less standard drinks per week. Now, this is of particular interest, and many of you will remember seeing what we called the J-shaped curve before. That curve that really demonstrated that people who drank 1 or 2 glasses of wine a day, for example, had an improved either overall risk of death or cardiovascular risk of death. One of the things that has really evolved over the past 10 years in the science around alcohol has been to look at who were they really seeing were the people that seemed to be having these beneficial effects. And when they looked into it, what they actually found was a lot of the people who were dying, who were not consuming alcohol, but were dying early, were actually people who previously had been drinking significantly, but stopped because they had significant illnesses. More extreme example, you can think of somebody who had so much alcohol over so long that they developed liver cirrhosis. And so they would be reflected as having no alcohol in a number of studies because that's where they were at the point. But they would also have had a risk of death that was linked to previous alcohol use. And so when they actually took those people out and they actually only looked at people who had abstained from alcohol their whole lives, that benefit of the small amount of drinking seems to go away. So it seems that the people who abstain from alcohol their entire lives, as opposed to those that stop once they're sick, really do live longer as a whole than others. So the 1 in 1,000 ended up being not per day, but rather, and this did come as a surprise and is somewhat hard to swallow, we understand, it was 2 standard drinks per week. And the 1 in 100 was 6 standard drinks per week. So again, that is your risk if you consume this much on a regular basis of premature death or of dying 17.5 years earlier than someone who wasn't. What was also very interesting is in these lower amounts, the risk for men and women was found to be the same. So we have focused a lot on women and men, but we found that that really is only the case with the riskier and later on parts. So that's another little shift that we need here. If you want, you can go to our website as well, and 4 reviews were commissioned on key topics: alcohol in women, per occasion drinking, alcohol violence, and alcohol and mental health. I'm not going to go into the specifics of it, but if that is something of interest, take a look. You may have seen in the media or online that August 29th, we did launch a draft version of some of these results, and we had an open consultation. What was quite impressive is in Australia, who had previously done the guidance, they received 50 responses, and we received almost 1,000. To us, it showed us that people living in Canada are really ready to start having a conversation about alcohol and are quite interested in this. And most actually answered it. I don't have a chance to go through it, but all the details, but most people actually found it to be quite usable. They did have an opportunity to submit any evidence that was missed. And in the final guidance that will be posted on our website on January 17th, you will see that every single one of these responses was coded by 2 independent researchers and summarized in an honest way for our scientific panel, who then incorporated changes as they need. And all the essential summaries of the public summary will be in that document as well. This was also a stage where the alcohol industry was invited to provide feedback, and if they had questions about methodology, that they could present it at that point. What was very wonderful was the fact that there were no significant methodologic challenges to the guidance. And so it felt that the robust process that they had taken, where they looked at almost 6,000 systematic reviews, was one that was felt to be valid and good. There's a couple of things that really came through that we learned from people in Canada. They wanted us to focus on the facts. They didn't want anything that was strict or a patronizing message. They wanted to inform people about the existence of guidance and the reasons for the existence. They wanted to keep the messages short, simple, and clear. And they really wanted us to be able to meet people where they're at by providing them with actionable guidelines on alcohol. So as a result, instead of going with guidelines or the low-risk drinking guidelines before, we decided that we're not going to make an assumption of what is an acceptable risk for someone to be taking. And that's part of what's important about the low-risk drinking guidelines. That kind of was something that was a little bit more difficult for me as a family physician to swallow. The old ones, although they drew a number, it kind of made that risk decision for everyone. And some people may be more or less comfortable with different amounts of risks. So instead, we're presenting it as a continuum of risk. The idea that 1 to 2 standard drinks per week will give you a no to low risk of alcohol-related consequences. 3 to 6 standard drinks per week increases up to a moderate risk, including 7 different types of cancer, which we'll talk about shortly. And 7 or more standard drinks per week have an increasingly high risk. What's really interesting about this is 2 pieces. The first is that every drink you add after that 7th one significantly and essentially exponentially increases that risk. But what is equally interesting is every drink that's reduced also equally reduces your risk of premature death and disease. That's especially true for people who drink a lot, which is part of why we wanted this continuum of risk. We didn't want a low-risk drinking guideline that wasn't applicable to people who are already consuming above those. We wanted a message to be able to resonate, even if you're drinking significant amounts, that any reduction is going to significantly improve your health, even if you can't get yourself down to the moderate or the low-risk level. So that's the first and most important message that's come out of this. People living in Canada need to be able to make educated, informed decisions about their own risk, where they want to be on this, and hopefully be able to make decisions that allow them, no matter where they fall on the continuum, to reduce their risk. The second thing that's very important that came out quite clearly from the data was that consuming more than 2 drinks in one occasion is associated with an increased risk of harms to self and others, including injuries and violence. And this is particularly true for men who drink more so than women. And on reproductive health, when pregnant or trying to get pregnant, there is no known safe amount of alcohol. And when breastfeeding, not drinking alcohol is safest. So we were asked to look more into sex and gender. And obviously, it is difficult to apply this to, for example, non-binary individuals, because most of the literature has really looked at it as a binary sex relationship. We don't know, for example, with trans individuals where they would find themselves. But what we did find is above the upper limit of the moderate risk zone for alcohol consumption, the health risks increase more steeply for women than men. But far more injuries, violence, and death result from men's alcohol use, especially on the case of per occasion drinking. So we've come up with 3 recommendations. The first is to reduce the risk of harm from alcohol. It is recommended for people living in Canada to consider reducing their alcohol use. And around this message here, and what we're really trying to get across in this new continuum of risk, are these concepts of pragmatism and autonomy. The pragmatism part is this idea that less is better, but it's your choice about where you find yourself on that continuum. Again, even if you're at the 8, 9, 10 plus per week, any reduction is going to make an improvement. And so you don't need to look at that one low risk drinking level. The second is autonomy. This is a right to know. And again, it's this question about risk zones. So for example, we've now come to understand that the risk for breast cancer can increase significantly. And so even with small amounts of alcohol. So we felt that the truthful, more open and honest one wasn't to suggest that below a certain amount, you were basically good to go, that every standard drink counts, and that any reduction in alcohol is beneficial, and that ultimately this is an individualized decision that people need to make for themselves. So, like we were saying, less consumption means less risk of harm from alcohol. It is unfortunately a carcinogen and linked to 7 forms of cancer. It is a risk factor for most cardiovascular disease, and it involves a significant number of injuries related to road crashes and violence. Part of the message isn't so much to tell people not to drink, but rather to say that it is okay not to drink alcohol. And what we found in our discussions is that in a lot of Canada, it's actually somewhat stigmatized not to consume alcohol. And we kind of want to make it a little bit more permissible to, if you choose not to make alcohol, that doesn't make you any less of a person. So what are the next steps? The next steps are, as we said, we're moving from this term of low risk alcohol drinking guidelines, making it now, Canada's guidance on alcohol and health. The clinical implications are that both physicians, healthcare providers, primary care providers, but also individuals themselves are going to need to take a much more individualized approach to risk assessment. So this is particularly the case of people with a personal or family history of an alcohol attributable condition. When we look at things, some of the things that are most related, and as I previously mentioned, risk of breast cancer significantly increasing as alcohol intake goes up, colorectal cancer, liver cancer, esophagus cancer, oral and pharynx cancer, and larynx cancer. And all of these documents will be provided as part of the final guidance as well. We're feeling that the next steps are probably to nudge this through really thought of and careful public knowledge mobilization, but targeted professional development to help people individualize where they find themselves on this. A revisioning of what screening and brief intervention actually does, because we feel that this tool will allow people to help their patients make more informed decisions, as opposed to just a binary, you have a problem or you don't. And we're hoping as well that this will promote increased knowledge and comfort in treating alcohol use disorder. One of the things that's particularly helpful about this, and that I really want to emphasize, is this idea, again, that no matter where you find yourself on the spectrum, any reduction is good for your health. And ultimately, there are a number of, as I'm sure many of you are already aware, because this is an area you're interested in, publicly funded and very available medications and therapies that can help significantly reduce alcohol use. The other parts are that we're probably going to be looking at developing some targeted campaigns for specific populations. We want to help encourage cost-effective policies. And one of the other recommendations in the guidance was, in addition to the consideration of governments adding health warnings, this idea of a standard drink labeling. As any of you who do consume alcohol probably understand, it's virtually impossible these days to know how much alcohol you're consuming at the point of pour. This is the case for beer, where what you might get from the beer store could vary from anything from 2 or 3% to 5, 6+%. It's the same thing with wines and spirits. So being able to know exactly in a bottle, in a can, or in a drink, how many standard drinks are there will help people. Because what we're finding is this is all good if you can understand your risk better, but it's dependent on you being able to accurately and understand your own consumption. And that's one of the things that we're really trying to help people understand. We think that standard drink labeling is going to be an important part of this. Some of the slogans you're likely to hear from us: less is more, drink less, live more. The more you drink, the higher the risk. As I mentioned, the big launch is going to be on January 17th. But really after that, a lot of the work will begin around knowledge mobilization and discussion. As I mentioned, I'm hoping we're going to get a few questions around the alcohol guidance itself, but I'd love any feedback you have, both around a knowledge mobilization strategy you'd suggest, how to reach you and your colleagues better, but also your patients and clients. And if you have any suggestions on where CCSA should be going in general to help address the substance use needs of people living in Canada, I'm all ears for that as well. So thank you.
Thank you so much for a detailed explanation on a different way for us to start thinking. We do have a question that's in the chat. And the question is, was there a sense of how many years it takes to see the illness occur on average when they were looking?
So that's a good question. Some of that is found in the various technical reports. It does become, and I'll just stop sharing at this point as well, so we can just talk. It does become a little bit more complicated with different illnesses and diseases, and obviously highly individualized factors, including risk factors. What we do see is, especially at those higher levels, the illnesses do begin earlier, and it does seem that at those higher levels, illnesses begin earlier for women in particular. But no, it wasn't really part of the larger analysis, and it'd be a little harder to tease out. But I'm happy to send you the technical report specifically around the various illnesses that break it down.
Great. And I guess I have a question. Are you developing any sort of shared decision-making tools to use for family doctors in their offices, those types of things?
Well, that's a great suggestion. Look at that.
Okay.
There's one already.
There you go.
A lot of the effort has been on this so far, actually producing the guidance. I have been so impressed by our team. Like, you can imagine the past couple of months and how much work it's gone into to just review so much of the public guidance. And they really took it to heart. They reviewed it for weeks and then just locked themselves basically in a hotel conference room for 3 days until they could incorporate it all. So I think actually some kind of decision tool would be a great addition. And it's one of the things I'm more than happy to talk to our alcohol and health team for sure.
Yeah, it certainly, when you talked about how it will affect that brief intervention, that would be great. And then also including medications, as we've done studies in Alberta that shows we're not very good at at using medications or pharmacotherapy in alcohol use disorder. But I see Monty has some questions, so I will hand the floor over to him.
There's just one question, and I think you kind of touched on it, but like, are you guys going to do some like harm reduction guidance as well? So like, focusing more on low alcohol percentage beer versus higher, and then watering things down, things that we kind of give tips onto our clients, or like pouring out and measuring out how much you drink as opposed to free pouring it.
I think that's a great idea. And so this is again where something like this, what I really like about it, obviously it's a little bit more complex, but it's more nuanced too. And so part of that, developing different messages for different populations, is going to mean we're looking to develop messaging specifically for people exactly who need more of a harm reduction approach than targeting the low guidance. We're hoping that people will consume it. We're actually hoping, and I think what is really interesting is the potential for a movement about how we look at alcohol in general. Again, without that clear yes, no, go point, we're actually hoping that instead of recommending, let's say, just moderation or safe partying in general, that the alcohol industry might actually focus towards producing more lower percentage drinks for people who are choosing that as well, or trying to reduce things. So I think that there's a lot of different ways that this can be implemented, but Monty, you're absolutely right that a harm reduction approach is going to be needed for people who consume significant amounts. And maybe you're a good partner to help work with us on some of those messaging for the more significant consumers. Because again, and what we learned from places when we speak to our colleagues in the UK is just this difficulty with low risk drinking guidelines, that once you're beyond that, you're like, okay, well, I'm beyond the guidance. Doesn't matter if it's 5 or 100, I'm just going to go for it. But really this idea that any drink reduction, even by 1, can have significant, kind of the same messaging that they really got out around tobacco, right? It was really effective. Any reduction at any age is good for you and your health. So I might be in touch, Monty, about some of that then.
Thank you. Anyone else on the line that would like to? Oh, there's Lana. Lana, do you want to unmute and ask your question?
Not really, but I will. Thanks,
Sorry,
Alex.
it's
It's
hazard
awesome.
of me knowing you.
Yeah, that's okay. I'm seeing a lot of like neurotoxicity effects in my population with alcohol. Very annoying thing as you get older. Just wondering if there's anything that is mentioned around that.
So it's a really that's a really good question. And before this, similar to Bonnie and maybe you, Lana, like I was working a lot with older adults or kind of unhoused, middle-aged, older people in and out of hospital. I saw it a lot too. And I think one of the things that was a little bit disappointing was that there wasn't more around alcohol and mental health, but the quality of the data was not quite as good. And unfortunately, when it comes to some of those neurotoxicity, some of the pieces around nutritional deficiency, I think, have been hard to tease out from the alcohol in particular. They really, as I kind of mentioned earlier, they took a really conservative methodologic approach, in part because this was the first time that the alcohol industry hadn't been directly involved. And so they really wanted to make it as strong as possible. So there are suggestions for sure, as we all know, that alcohol is linked to brain injury and cognitive dysfunction. But it just didn't meet the muster of the bar that they had set for themselves for there, which again just speaks to how strong the evidence is when it comes to those other cancers and various things. But again, it's something I'm happy to take back, because I know we're going to be producing a number of other reports, and it might be one to talk about particularly like how the guidance should be used for alcohol in aging populations or people at risk of neurotoxicity in some way or another. So it's something I'm happy to take back to our alcohol team. They're always keen to do more and more.
Great, thank you. I guess I'm also wondering about the public campaign, because this is a significant change from what we've been telling people for years and years. And yeah, I anticipate there's going to be, some challenges there. And just wondering about that public campaign and how, as family docs, if we do have those shared decision-making tools and harm reduction tools, but how we can meld those together. What are your thoughts?
Well, I mean, one of the things that has been just really impressive. So I think we're all tempted as family physicians, once we understand that something is a little bit more dangerous than we first thought, is to run out and kind of, my first gut instinct is to always kind of do the Chicken Little, like the sky is falling. But I think we've all kind of come to slowly understand that that's not a very effective way to produce change. What has been really interesting is how well this right to know idea has empowered people. It's just kind of this idea that your understanding of alcohol is probably not fully informed. And I think we have a unique opportunity coming out of COVID, where so many people really took a personal interest in their health and decision-making around, when to get vaccinated, what to do, where to go, but also just decisions. They want to participate more in their healthcare and decision-making. So we feel that it goes really well with that. And I think that's going to be a lot of the conversation we're hoping family docs will have with people, is kind of this idea of, let's make you as informed as possible and then decide where you want to situate yourself. It might be a good idea, for example, to help them understand other risks they take in their life and how this might compare here, or understand their personalized risk, right? When you're dealing with patients who have a history of breast cancer, when they bring it up. But I think we are finding that this kind of right to know idea is really resonating, and people aren't feeling that they need to push back against it, or feel that we're mandating or telling them what to do. So I'd encourage kind of some variation of that, but hopefully we're going to work on fine-tuning the message somewhat.
Great. And any thought of like an app or where they can sort of adjust their risk and then come up?
I'd love that if you have a little bit more money. I mean,
okay, you don't have endless supplies of money. Okay.
Unfortunately, this was already done. So just so you know, this was done on a surprisingly small budget. I'm really impressed by the team. If we had more money, I think we'd love to design an app, various things. And this is kind of where, again, we're going to need to prioritize things. So understanding what is most likely to have the best uptake. But yeah, I mean, eventually having something that allows people to understand and personalize their risk in their phones would be fantastic. I think we'd love to get there eventually.
And Laura Nixon has a question. Any chance widely used tools like the Canadian Task Force on Preventative Health, BRCA, it just disappeared, a tool being used? Any thought of adding risk associated with alcohol to their tools, maybe a collaboration?
Oh, yeah. It's a really good question. And we're meeting a lot with public health officials. The Canadian Cancer Society wrote a wonderful op-ed in support of it. So actually we're looking at kind of a broad whole of health approach, and we're looking to partner with all these folks. It's a very good suggestion, and I mean, maybe that's one of the ways is to get things into other people's tools that they're already using, as opposed to asking them to use a whole new other tool. And then I think there was another question up above that I might have missed, sorry, around, are there clinical implication risks for males available? Yeah, so we can send you, and maybe Kathy, we can link to some of the technical reports and summaries that were done. But we're going to be part of the campaigns, and both the ad campaigns and the knowledge mobilization campaigns will be specifically around the clinical implications that towards men. Some of the focus around things like testicular cancer or pieces that they might be. A lot of the focus around men, and this is kind of one of the next steps that we really want to look at, is the harm to others piece of it, right? So we know that men's drinking is much more linked to that violence piece. And so I know it's a little outside of the clinical implication, but I think it's one of the things that we really want to help people to understand. Oh, and there's some other ones, sorry.
Yeah, you got a couple more there. A benefit in decreasing drinks, any evidence for fasting, like a dry January being beneficial?
So that's really interesting. I don't know that there's evidence for that. if you, so the dry January part is really interesting, right? Part of it is to give people a break from alcohol, but it's not really, what's really interesting, what we hear people say that they report that they like about it isn't so much that it's going to improve their health in and of itself. It's kind of an opportunity to test out what alcohol, an alcohol-free life is. Kind of understand where it is kind of an opportunity to just do a check-in with what is my relationship with alcohol when you try and take it out. And what has been really interesting is like dry January will often spread into like people trying to do it for a spring season or something like that. And it really does kind of just ask people to, you know, look into their bank accounts and see how much more money they might have, or see all these different pieces. So there's no evidence to say that that in particular is beneficial. I think there's building evidence to suggest that kind of, there's different words for it, but one of them that's frequently used is sober sampling. But that there's evidence that just kind of that trial in a judgment-free area, you're not committing to stop alcohol for any significant amount of time, you're just doing it for a month, will push more people towards both entering themselves into treatment, but also looking at cutting down their use than otherwise. So I look at it as an individualized thing, but I see no downside to kind of suggesting, why don't you just take a break and see what it's like, be it in January or some other time. I think Quebec does it in February because, you know, it's Quebec and they got to do everything a little bit different. But
And we just have a comment in the chat. The strategy also helps take the shame out of the situation, more evidence-based, but still really person-centered. So
yeah, thanks so much, Flo. And one of the things that was really clear in the public consultation feedback that we received is we got to make sure that although we're trying to reduce harm, we're not stigmatizing people who drink. And that's one of the things we really like, stigmatizing people who have an alcohol use disorder. And so that's one of the things I think we're, as physicians, we have to be really cognizant of in interacting with our clients too. But thank you for that comment.
Yeah, that's great. And I know that we're supposed to go to 8:15, and so we've got 1 minute. And so I just want to thank everyone. And if there's any last minute comments from either Monty or yourself that you want to bring forward, Monty unmuted.
No, I was just going to say, like, I know a lot of you are having concerns about the Narcotics Transition Services regulations. Just so you guys are aware, the AMA will be sending out a case-based template for all of you guys to fill out. So if you got a client who you think may not benefit necessarily from these narcotic transition services, and that might be problematic to get them into these services, please share that client story on this template. We're hoping to present this to Alberta Health and the ministry in the near future so that they can better learn about the situation that many of our patients are facing. So that's just a heads up that's coming pretty soon.
Well, thanks so much, Monty.
All I'll say is please reach out at any point, both to myself and to the organization, if you have any questions, both about what we were doing, or if you're just interested in potentially partnering on implementation pieces around things like the guidance. Don't hesitate.
Thank you so much.